Thank you for attending today's presentation featuring Dr. Jim Chimiak. I hope everyone had a chance to watch the 1-hour pre-talk video on the topic of COVID-19 and diver health. It's not a problem if you didn't get a chance to watch that. The highlights will be discussed in the presentation today, and you can also refer back to the video after this presentation. The rest of the agenda for tonight is as follows. A brief 10 to 15 minute presentation from Dr. Chimiak, then a Q&A portion. I know some of you submitted additional questions. Please feel free to ask them after the presentation in the chat box, and I will moderate the Q&A portion of it. Dr. Chimiak is the medical director for the Divers Alert Network, which is also known as DAN, and has been working with DAN since 1991. He is triple boarded in anesthesiology, pain management, and hyperbaric medicine. He is a qualified U.S. Navy surface warfare, special operations, mixed gas salvage, undersea/diving medical, flight surgeon, and saturation diving medical officer. He has worked as an ER and family physician, a gas-free engineer, and led USMC surgical platoon during the invasion of Iraq. Dr. Chimiak is responsible for all medical issues at DAN. That includes both emergent and routine calls for assistance for diving medical issues. He assists divers worldwide and their local medical providers with timely current medical information to expedite optimal care and evacuation when necessary. He is actively involved in research, writing, as well as review of all medical information leaving DAN. He works closely with breath hold to commercial/military divers. That includes hyperbaric medicine facilities, diving training agencies, NASA, US Coast Guard, US Navy, UHMS, EPA, and the NOAA. Without further ado, please take it away, Dr. Chimiak.
Thank you. It's a pleasure being here, and wish we could all meet in person, but these times demand this kind of interaction. So if you could bear with us, we will just go ahead and proceed with the talk. As was in the introduction, we're going to go over some of the high points of what's new, what's changing with the COVID and diving, and pretty much take that talk and gear it toward what is probably most important to all of us, diving, and how that impacts our diving with COVID-19. As you know, 2020 has been an incredible year. It started off with the recognition of the COVID-19 epidemic and some of the problems that we encountered. Some of the solutions, some of the problems that were occurring were quite interesting. The fellow on the left, looking at some of the things of using some of the dive equipment to help in the pandemic, to help isolate or to prevent the spread of infections. Divers, very ingenious bunch, came up with a host of different problems, something like this, to the full face masks, even to the helmet that's used in hyperbaric oxygen that actually does seem to be of some benefit. There were some dramatic responses, and that's some of the things we have to be very careful about. Those initial responses were sometimes would sometimes appear heavy-handed, but at the time, that's usually a good approach to take, is a very conservative one. We even had massive naval hospital ships pulling into some of the bigger cities here in the United States to help with areas that had the pandemic affecting them greatly. Fortunately, most of those resources were not needed at that time, and actually were pulled back, fortunately, and the local hospitals were able to mobilize and take care of the patients. And then, of course, the various preventive techniques and ways to prevent the spread and to limit that transmission particularly to the more vulnerable populations were taking place. And of course, culminating with an extremely rapid development of a effective vaccine. In fact, several vaccines that have been very, very interesting novel vaccines that have been very helpful in dealing with this. So where are we? At first, the heavy-handed approach again. No diving. You weren't even allowed military service, if you had a COVID-19 infection, fortunately, that's, as you can see, has been crossed off the list, and we can see that that's no longer anyone's policy that I can see at this point. What we're looking at is how COVID-19 affects individuals, and there's a host of organ systems, and this is probably a good way to approach it. There's psychiatric problems that you hear about. The long hauler is the term you hear, people with COVID symptoms after the initial infection, and months to recover from those. And psychiatric was one of them. You have to coat that with the idea that any chronic disease, especially one that required an ICU or even a stay in the ICU where you were intubated and sedated in the ICU, that there are a considerable amount of problems that occur just from that. And psychiatric problems are arising or being identified, PTSD, anxiety, a brain fog is what they term it. There's neurologic issues, some Guillain-Barré-like symptoms, some numbness, some tingling that may persist. Dermatologic, you hear of the COVID toes. This may be more related to the vascular aspects of this disease. GI symptoms, it does affect gut. There has nausea, vomiting associated with it, and also some of the loss of taste and smell. Renal function has been looked at. Again, the interplay between a severe disease or difficulty with the disease and its interplay with the kidneys. Musculoskeletal, you can see from lack or being in the ICU, some deconditioning, some problems with joints, some myalgias, things of that nature. And where are we getting this information? It's from previous infections, the MERS, the SARS experience, and looking at and throwing them forward. And that's where a lot of the information early on was being taken. But now we are starting to get folks that have recovered from the COVID-19 and are returning to play, returning to work. So now we have both the push for athletes and individuals to return to play, which was a big issue as far as can college athletes go back on the field and what kind of problems could we expect or do we have to consider. And then now we have large COVID clinics in which we're looking at patients post-COVID and helping with some of those issues that individuals have experienced both acutely and then, of course, post-COVID. And we at Dan, of course, are doing the COVID-19 observational study, looking at individuals as they went through the system and we'll talk about how they went, how to go, some ideas of how to go through the system. And some who have returned to diving. Again, various approaches have been made by these individuals. So what it breaks down to is the respiratory, the cardiac, and the hematologic aspects that are most of very big concern to people returning to play as well as to the diver. And we need to talk about that very delicate balance of being the respiratory system with the cardiovascular system and being able to get that blood to those aerating elements of the lung and be able to deliver the oxygen to the body. In addition, we also have to be concerned about the vascular system itself and the impact that COVID has on the actual endothelium. Well, first, everyone focuses on pulmonary, and rightly so. It's a respiratory tract infection. It seems to have a predilection due to the receptors, the ACE receptor, ACE2 receptors. And so the lung is certainly populated by them, as well as other tissues in the body. And that's why the organ systems that we were looking at previously, why there's some effect on each one of those. We are especially noteworthy is the idea of hypoxemia. The individuals coming into the hospital usually is one of the reasons that they are both admitted and perhaps even taken to the ICU and even intubated to go and address those issues. Because of that, if one is admitted to the ICU and one has some invasive resuscitation and intubation, there are problems associated with that independently. The ventilation that that is required, the impact that that has on lung, particularly lung that has been infected, and some of the problems that happen to the lung itself. Also, being ill promotes a coagulopathic state that can result in pulmonary embolisms and even microthrombi that seem to have a considerable role, and increasingly so, being identified as one of the bad actors that affect a COVID-19 patient. Then, of course, there's the secondary bacterial infections. This happens with viral infections where a bacteria infects the lung and can exert considerable impact on the lung itself. It has resulted in some of the problems with bacterial or antibiotic resistance for those infections. One of the issues that we're going to have to address is the idea of recovering from COVID is the identification and looking at chest X-rays, CTs, and the findings that we may subsequently discover, and how that will impact the determination for a diver to return to diving. Looking at some previous studies, it seems like about 3 to 6 months there was a fairly decent percentage of folks that recovered from that illness. One that's has attracted quite a bit of attention, of course, is the cardiac problems. The idea of myocarditis that can occur as a result of the infection. Again, the attraction of the virus to those tissues can result in myocardial infarction, arrhythmias, heart failure. But we also have to note that other viruses too can cause problems with these very same things, and ones that we may already be familiar with, like adenovirus, H1N1, Coxsackie, herpes, parvo, influenza, can also have some effect on the myocardium and have similar problems. And there's a variety of both laboratory tests as well as EKGs, echoes, Holters, cardiac MRIs, D-dimer, CRP, things that, dual energy CT, that can be used to help evaluate the extent of the injury. Now, again, as we talked about early on, some of the studies that came out, for one reason or other, came out with some very, very dire warnings about the disease itself. And many of you probably are aware of some of them that talked about even asymptomatic individuals with pulmonary problems that were permanent and seen in the majority of such patients. As we follow for instance, the cardiac literature, you're seeing a easing up of this as better studies are conducted, those that are randomized, and most importantly, when the very fine measure is being utilized, what is really abnormal and what was something that may have been baseline. Athletes, for instance, can have some changes seen in some of these tests that are normal for an athlete. And so some of these were read as such, as an abnormality. And so, although reported as such, the news cycle was so quick and fast, and always wanting that brief thumbnail, that they were oftentimes blasted worldwide with considerable angst caused to many individuals. We just recently, in January, a very good study was done on college athletes, and looked at one of these diagnostic modalities, and found out that indeed that the incidence or the findings were not anywhere near those reported earlier. And in fact, that modality was not recommended by these investigators. Hematologic is probably a very interesting one, and one that's, again, subject of great interest, and that is the development of blood clots, thromboembolisms, and eventually, pulmonary embolisms, microemboli, and being able to investigate this, to be able to look at the vascular endothelium, which again has those receptors in which the virus gains access, and its interaction with that endothelium is very important. And long-term injury to that endothelium is something that we are all very interested in, as whether this also repairs with time. And does this lead to some of the manifestations that we're seeing, such as hypoxemia? What has happened is there has been more use of anticoagulation to help combat this, and it seems to be somewhat effective in dealing with some of these problems that afflicted someone with COVID, a more moderate case. But I guess everyone sits here and says, well, what can I do? What else can I do? And it's always good to be, it always feels good to be active as well as just passive, or waiting for that shoe to drop, so to speak. So I'd like to say that one of the silver linings with COVID-19 is the recommendations that we're going to talk about here are something that we can carry forth, even, if COVID goes away completely, we never see it again. Some of these things might be very helpful that, we all are now in our lifetime seeing this, and now we'll find it important to implement in our day-to-day practice when we dive or in day-to-day life. And so, I'm sorry. The first one, of course, is avoiding the infecting of yourself and others, and those are some of the things that you can learn. Obviously, CDC was going through a trial phase as far as how to go ahead and how to set this up. What's the best ways? What's the best either disinfectants? What's the best way to go ahead and space folks out? What are super spreader type situations where there's a high chance of being infected, and how to avoid those. Personal protective equipment became a center, although used since 1918. Some of these things that have been used before has now gained some considerable amount of investigation and a good look. As we work in the OR, we've been in masks, and some of the principles the reasons we wear masks in the OR are used certainly to justify some of the recommendations that are being disseminated by CDC. These things are becoming consolidated. The data, the facts are coming out. Early on, it's very difficult to produce facts. It's easy to produce, as we all know, opinions or suppositions or extrapolations, and those that are prone to do that. And then the actual construct of actual data is now coming in, and some really good information is coming out of all this, and will probably guide good measures on into the future. Vaccinations come to the forefront, the discussions about using vaccinations, the idea of facilitating the process that we can get involved in. There's an orderly process that's trying to do to so much vaccine, so many people to administer them, who gets them, and coming up with some logical, rational ways of implementation. Very good idea. The idea of looking at the actual vaccines themselves, they're quite novel, as you well know, ones that are not of the sort that we've seen in the past, and their effectiveness is quite impressive. And then the last topic, and one that I think always needs to be discussed, and that is fitness. It's probably one of the most important part for a diver. It's discussed, everyone does the exercising, but the idea of to actually prep yourself for the marathon, for a future illness, for a bout of COVID, is the idea that this is a good time, a very inexpensive way to go ahead and get yourself ready for any sort of problem as far as COVID is concerned. But just as importantly, and what Dan harps and any good dive medical doc will preach and on about keeping yourself in good shape and having very good exercise capacity. This is important not only to prevent COVID and some of the absolute benefits you get from exercise, but also it will prevent some of the problems that we've seen, irregardless of COVID, going forward. You know, some of the biggest numbers, of course, are the cardiovascular problems that we see in divers, and both in severe injuries and even, and of course, death, resulting from not being prepared in such a capacity. It also gives you the confidence and the ability to overcome when the situation changes quickly and puts you into a situation that you had not anticipated for your dive. The benefits of exercise are many. I've just listed a couple, and mainly because they have their impact they have on COVID, as we all know. Again, because of the short talk, we're not going to talk too much about COVID itself, but the idea that obesity has an impact, hypertension, diabetes, these can be exercise has a dramatic impact on diminishing these conditions, and also because they are risk factors for cardiovascular, neurocognitive, neurovascular problems, they subsequently will have an impact on those too. They'll be very important for those if by some chance you contract COVID or any other serious respiratory illness. It's very important to know your baseline level of fitness. During the study, I talked to several, many of the folks that have contracted COVID, and it's very important. It's very helpful when they have had an exercise program and they know where they were with their run, with their rowing, or they may be on an exercise bicycle or such, and they'll be able to say, yeah, I've gotten back. It was about a month and a half before I could go ahead and take the bike out for my normal timed bike up a hill or whatnot, and they can give some information. It's helpful and it's practical. Without that, then we have to rely on normative data, meaning that what is the normal for age, and that is an extremely difficult number to really put your finger on and can be quite variable. There's also some formal CP testing, which again requires specialized equipment, going to hospital, seeing a physician, going ahead and going through some testing, and that's another way to do it. But getting your baseline fitness numbers and knowing them and working up to those numbers are quite helpful, I think, when we finally agree upon a very good way of getting divers back in the water. And there are just hosts, and these are coming out. We've seen more and more of these coming out as individuals are returning to play. And sports medicine cardiologists were confronted with an incredibly difficult job with not a lot of data, but the very gut-wrenching question of, can someone with COVID return to high level of exercise or sport or competition without undue problems? And we discussed that earlier in this talk. You know, the idea that someone would have an arrhythmia resulting in sudden death on the playing field or going to congestive heart failure is the idea of being able to look and look at the individual and decide, do we put them through a host of tests that sometimes can be false positive or be so sensitive that we will eliminate quite a few from competition or delay their return to play unnecessarily. On the same token, you do want to stop those that will have some problem as they go as they compete, as they tax their systems, both their cardiovascular systems in competitive play. A really good attempt was done by the dive medical docs out in San Diego University, UCSD, and they came up and they looked at some of the information that was put out there by sports medicine cardiologists, and they came up with some idea of what are some good ways of looking at the problem, and it's pretty good. And I suspect that there'll be some additions, some subtractions as we move along and we see what actually does need to be in there. and what kind of problems did we actually see for those that had any abnormality that was detected. But it was definitely a good start. I think it will be changed some, but not much. This is probably, I just put this in just a little, downshift here, and that is just to, add some sense to this, sense to it all, is that we have to be very careful, because if we order, it's easy to order a plethora of tests and require them. The problem comes on is, what is the justification, both in cost, and also what happens if we find very, very small disconcerting findings that we really don't know what they are. I mean, we could find tiny blebs. We can find small abnormalities of the heart that aren't that we haven't looked at well people before, and so subsequently we may be disqualifying them with a knee-jerk reaction. And there's sayings that if you haven't found what's wrong, you just haven't ordered enough tests. And eventually we'll find an abnormality, and the idea being that might be a overcall or a false positive. And even Sadler admits in states in the papers that CT may be overly sensitive, and we may find insignificant lesions, tiny small blebs, for instance, that may result in the disqualification of a diver from ever diving again unnecessarily. This is a quick, again, as we're moving along and we're having these COVID clinics, we're getting more and more information about what kinds of things we're seeing, some of the symptoms that we see, particularly in the long haulers. Those are those that recovered from COVID but still have symptoms. And fatigue, chest pain seem to be a very common problem. And these are, they resolve with time. There's a number of things that both have been found or postulated that cause these problems, and some benign, of course, and others more serious in nature and require workup and perhaps some further investigation for that etiology. There are also other symptoms, again, as we talk about in like the less common physical symptoms, the idea of things that are associated with individuals that have the COVID. They can be attributed to the COVID, or they can actually be attributed to perhaps a prolonged stay in the hospital. Some of the in some of the studies that came out of China, obviously they initially were hit, is the social implication of having COVID-19 had some very profound impacts on how people related to these individuals, and may be part of the reason for the anxiety, the depression that just continued on into weeks and sometimes even months into that person post COVID infection. They all mention that there is some problem with the quality of life following a symptomatic COVID infection. So as you know, I like to look at this now is we looked at COVID as a disease and how it affects everyone. And of course, these processes, these problems are going to affect divers. But specifically, the issues that we're looking at from the get-go was oxygenation of a diver, the endothelial damage that we talked about, since that is the highways that bring nitrogen to the tissues and bring nitrogen back out of the tissues, and the idea of the effects of hypoxia, low levels of oxygen, the first being high levels of oxygen, and the effects it may have on pulmonary oxygen toxicity, are all raised and certainly are difficult because of the small numbers that we're dealing with, and the fact that diving has definitely been restricted over this last year. So give you kind of a feeling that those that, you know, when I was in Navy, we that was our dive rig. But the idea of when we went down, for instance, to pick something up, or we were doing recovery, a lot of times you didn't know all the facts until you got down there. And when you were there, you couldn't see it. So you might be working on a problem and you're working on this, but eventually you're putting the pieces together, you're describing it, and eventually you're bringing that up. And indeed, you get a clear, the light of day picture. And that's essentially what I like to convey, what we've been looking at, and the idea that early on, there were some questions about COVID being some sort of special, unique virus, which it appears to have some aspects of that. But again, it has some of the characteristics of a serious respiratory tract infection, in which we can borrow from other sources. Some of the problems we see in the ICU and things of that nature. The development of ARDS, that's a condition that occurs with folks that are very sick, that are on ventilators. And some of these things, that we have to pare them away, but be cognizant that individuals that may have been severely affected by COVID will be affected by these things that we know of from the past, and something new with the COVID. So with this one, we've developed some very interesting vaccines along the way as we got to understand this, the proteins that are involved, the coding, the viral coding of the virus itself. Various treatments were first proposed, as you could remember. Some very interesting ideas were proposed, and it takes time before you actually can say, no, these didn't work as they did some of the studies. And there seems to be development of some therapies. As you know, viral illnesses are just one of the worst to treat, unlike bacterial that respond oftentimes to the correct antibiotic. Viral illnesses, particularly viral pneumonias, are very, very difficult to therapeutically treat rather than a subjective approach to them. The idea of developing herd immunity is the idea: can we limit this both with individuals with immunity to the virus, and decreasing that spreadability, and having that block the rapid transmission. There's a number they use, and the idea of not allowing this number to be 1 infects 2. We want it to be 1 infects 1 or less, and we start moving the pendulum in the right direction. Protective measures being instituted, those that are correct. It's easy to come heavy-handed, but it comes with a price, and everyone can give stories of, shutdowns, closings, and this sort of thing, and they have costs too. So as we institute these measures, were they necessary? And we're starting to see some pretty good epidemiology and public health specialists coming forward with what are effective and the truly bang for the buck. The disease is better understood, as well as its process of how it's transmitted. And then, of course, the phase openings, which goes along with those that are going to keep that transmissibility down to a minimum. So those are very helpful. So we get to the crux, and essentially what we all want to know about COVID itself, and that is it's in various phases. The first is what we talked about earlier, the pre-infection. That's those that aren't infected, those that have the ability to go ahead and shed those pounds, get down to a ideal body weight, take the smokes and chuck them finally. Good reason to do so. Get yourself in good fitness, good shape, so that you can, as I say, run the marathon, and this will reap rewards just from underlying cardiovascular reasons, as well as just general good health. And also, this is a good time to take a look at your medical conditions and get those well under control, whether they be asthma or diabetes, is to get these things under the best control possible. Hypertension, get your blood pressure under good control. The prevention we've talked about, and those are the measures that I don't even want to say it, because I probably will get a little PTSD in most of the people that are listening. We've heard it over and over again, the various ways that you can prevent infection and things you can take in your day-to-day lives and your operations. The vaccine will big into this, of course, and that is the idea of being able to prevent transmission of that of the illness. The treatment in the acute infection phase, that is those unfortunate to have gotten the infection. As we know, there's a considerable amount of attention given to those that are asymptomatic, or those that are asymptomatic before they become symptomatic, and the infectious phase. That infectious phase is very difficult to be able to determine by normal things of appearance or symptoms or fever, things of that nature. So this is an issue that has made this a rather difficult public health problem. After getting the infection, the recovery phase, this is the period of time that can last weeks to months. There's a look at the idea of grading it to the severity of the illness, looking at it from our point, like an anesthesiologist, we look at various respiratory tract infections seriously because of the impact that a common cold has on the lungs and on the respiratory tract, and the reactivity that it causes. Looking at these facts and some of this information that we have from the past can guide, at least giving us some idea that it may be weeks to months before you return to diving as a result. So after you've recovered, no longer infectious, of course, and then recovered from the illness, one is being followed by your physician, and that physician team looks at you and can give you specific guidance as far as, do we need some additional tests based on the symptoms that you're giving them, and also guide your rehabilitation and your fitness program, because we want to get you back to diving, we want to get you back to your day-to-day activities. But we have that concern that immediately after an infection, we're concerned about some of these cardiopulmonary aspects that we talked about earlier. So this rehab, this fitness is probably the one of the dicey areas that as we move forward with the program to get one back to diving. So after one is asymptomatic, there's no problems. You've got back to full functional recovery, and that is, are you back at or equal to or above your previous fitness levels? And at that point, that's pretty much a straight, I would say, no-brainer. As we move this down into see your diving medical physician, or consult someone who knows some about diving medicine, describes any of the issues, and then go ahead and release to conservative, complaint-free diving before we engage in deeper, longer, technical, that kind of things, dives in remote locations. My recommendation is to do this in a controlled area where you can see if any problems you're having with the diving, is to bring it up with your diving medical physician. These will become manifest even on a regular or a checkout dive, so to speak. Remember, it might, and especially after this last year, it might have been over a year before you've been in the water. So it's very important to get that familiarization with your equipment, make sure it's checked out, and of course, the most important is make sure you're ready for that exposure. And I think that's very, very important also. So in closing, just to say that people are able to dive, following some of the things that we've talked about, cognizant of a group down in Florida that worked with kids, scouts, and got these over 5,000 divers in the water in various locations, from their day boats to the liveaboards to some locations actually in the Caribbean, where they've been able to effectively get their dive teams through without incident. It's regimented, it's the scouts, and they run in a regimented type of program, and they used isolated groups that went through and were able to partake of diving and do this effectively. So I leave that with the idea that, yeah, there is diving that can take place even during some of the highlights of the problems, and conforming to some of the things that I've talked about here today, and certainly the things that you've all read on the CDC or certainly in the lay press. It does work, and there's many people working on this problem, and really a lot of talent has been afforded, and it will be helpful, as I said, a silver lining for all of us, for divers, for a long time to come as a result. And I think some of these things we'll learn will have, I think, a better live aboard experiences as people come on board and are cognizant of small confined spaces, about coming on board with illnesses, GI particularly, and bringing them on board, and ways of dealing with that and isolating and not doing that to others. So I leave my number up here. This is our number if you ever have any problems for this or any other reason. And certainly if you know of anyone that has COVID, please contact this number, and we would love to enlist them in our study. We have a few questions here, it appears, and
Yes.
we'll that in.
Thank you so much for the informative presentation, Dr. Chimiak.
Oh, thank you.
I'm going to go through the 4 questions that were submitted prior to the presentation. If anyone has any questions, please submit them in the chat box and I will moderate. Our first question is Jeff. I hear very often, I cannot scuba dive, I have asthma. I tell prospective divers that if their asthma is under control, they should ask their family doctor if it is appropriate for them to dive and provide a medical waiver for a dive association or reference. Dan's current recommendations gives advice for physicians. Do you think a regular family doctor is qualified and should be expected to make this judgment? Should I be sending prospective divers to a physician specializing in dive medicine instead? We do not have easy access to physicians, excuse me, with dive medicine experience in Canada the same way.
Well, very good. This is a question that's, I mean, if not just for Canada, it's hard to find individuals that are find dive medical physicians in some locations, particularly if they're not around a dive location, especially those that travel to destinations. So the idea of having dive medical physicians is probably something that probably will never occur where there's a adequate number of them. Having said that, the whole push at Dan and other organizations is to provide information so that it's easily digestible, easily understood, and things that a good family physician, internist, primary care physician can understand and look at and understand if they have a problem or they don't have a problem. And so we give the guidelines, we try to make them very, very simple. Dan has some nice cards for those that do see divers, physicians, that they're infographics that give just the facts. And then occasionally you're going to find that diver that just gives you the little bit of the willies, I call it, that he's not quite under control. And the idea is to again employ a consultant. Does not have to be dive medical physician. It might be a pulmonologist, cardiologist, depending on the problem. And in this case, a pulmonologist to go ahead and try to get this individual under control. And then we'll see if they'll be able to, if they're under such good control that we can get them on a vessel, get them diving again, if so be it. There's always the out for any physician that's having difficulty when you're dealing with them is to call Dan or a dive medical physician that you particularly like to deal with that may not be in the area. And that's very helpful. When we get on with a good physician that is a solid, physician that deals with asthmatics, it's very easy to describe. It's easy to describe the diving problems to someone who has a good grasp of the physiology and medicine in general than vice versa. And so it's usually a very good experience. It helps them on a future case or someone after them or dealing with that individual. So the short answer to that is essentially yes, your family physician can take care of those. When they get out of hand, see the consultant, And then certainly if both the consultant and the primary physician still has problems, they don't quite fit the guidelines, then give us a call, give a dive medical officer, a physician a call, and we'll be more than happy to help get that individual in the water if they want to. It's recognizing the risk. It's describing the risk to the patient, physician, and of course to the dive instructor or master who's running the dives.
Thank you so much. So Terry has a question. I would have deals with the use of prescription medication for those of us who have high blood pressure and use medication to control it. Some medications may interfere with the normal absorption rate and therefore either increase or decrease the blood pressure. What medications are acceptable and which are not? A second medication is a blood thinner, such as Lixiana, sorry, I'm butchering that, which is similar to baby aspirin, I understand. Any concerns on these type of medicines?
This is a good question. We could almost talk a whole period on this, but the bottom line on this is usually when it comes to medications, the first thing you want to look at is why are you taking them? So you're going to look at the underlying medical condition. So in this case, I think the questioner was asking about hypertension. So we would look at what kind of blood pressure management has he attained? What kind of complications does that person have as a result of their hypertension? Do they have cardiovascular? Do they have a cerebral vascular illness? Do they have history of stroke, previous MI as a result of it? And do they have any other risk factors? Because this will then guide us toward the idea that before we even start talking about medications per se, but more precisely, some of the significant risks that you might experience from, say, a high elevated cardiovascular risk that needs to be investigated first. Now, getting back to the actual medications, there's things you do need to look at and be apprised of. Some medications can cause, like a diuretic, you might have some questions or issues about electrolyte fluid balance, depends on how much and what you're taking for. The idea that are these levels going to be changed by anything that might occur, particularly if you go on a liveaboard or you're going over to a remote area, how that change of diet, the fluid intake that you may experience, and any other medical condition that may impact that. Because I think you had a good question about drug levels that may vary when you're in these areas. One common malady that could happen is seasickness, and the idea of how does that impact the drug levels that these medicines are for. I'm talking generically again about medicines, and I'll focus in, on the hypertensive question that this caller was asking about. But the idea of if you didn't have that medication, what would be the impact, or the levels were lower because of it? Those are impactful questions too, and something that the individual should keep very good close track of, because if you're on liveaboard, there's a good chance no one else is watching these sort of things. So it's very important that's part of the progress there. Anticoagulation is again almost a whole issue on itself. The reason you're taking an anticoagulant is often very telling, very important part of the equation, but also the idea that you are subject to bleeding. So there's various things that can cause that, barotrauma being the most common. Of course, any structure that subject to barotrauma can cause bleeding. The idea that you're anticoagulated could increase that amount of bleeding that you experience. In addition to that, there is a theoretical risk, and I say theoretical, although we do see this in very severe cases of DCS, where the spinal cord has been affected. There has been tiny petechial hemorrhagic lesions that have been identified, and subsequently bleeding, an increased propensity to bleeding could make that injury more profound. So it's something that needs discussion, and the idea of more conservative measures to take so that decompression sickness is not an issue. But again, underlying, if I say top 3 thing, underlying condition is probably the most important as you talk about anything to do with medications, drugs, anything of that nature.
Thank you so much. Our next question comes from Dragon. What have we learned from MERS and SARS, which we can expect to be applicable to COVID? In particular, were there permanent effects that would prevent a reconvalescent from diving? Were there effects specific to the viral disease, i.e. something that would not occur if a person got sick from a different cause, example, like pneumonia? Florida Seabase was mentioned as a success story, getting 500 divers through their program without any infection cases. At what percentage of full capacity did they operate? Advanced screening before the divers even arrived at the site, how did that work? What would cause the diver to be turned down? Thank you.
All right, that's a good series of questions there. I guess the first thing is exactly as we talked about earlier, that MERS and SARS impacted some of the thinking that went on, that indeed, viral pneumonia, what would happen, what were some of the ramifications. Oftentimes, again, as we talked about, if you go into the ICU for any sort of viral illness, what can happen to you, and what's some of the problems that occur, ARDS being one of them. And so we look at this a problem from a point of view of what are common to viral pneumonias and what is specific for the COVID virus. And so trying to pick those things separately is difficult. Now, having said that, there's probably, I don't know, anybody on the planet is not aware of COVID-19. May be a stretch because of the fact that it seems to have infected all aspects in people's lives. So as a result, it's being studied. The idea that there would be a study for SARS divers, I'm not aware of one. The idea of looking at what the impact or how folks recovered from the SARS, those are that's the one study I put in there where they saw in about 3 months, you started seeing a dramatic rebound in those that were affected by that infection. How that will correlate with COVID, no one wants to jump forward and just say, absolutely, this is the case. We had a lot of people jumping forward that were looking at COVID patients rather early, or those that were very, very sick, and obviously would garner most of the attention early on, and rightly so. Now we're seeing asymptomatic individuals that we've identified, those with very mild symptoms, and now we're seeing a lot, I would say, a milder picture than what some of those earlier case series, or a few of the cases that were described, some as little as 3 to 6 individuals being identified. So going forward, I think these stories, each time I'm looking, seems to be kind of lessens the dramatic impacts that we probably all have seen circulated on various blogs and whatnot, and hopefully this will continue. Again, we don't want to shortchange or jump ahead and not acknowledge that there's still things to be gleaned from this, still things to know. The impact, like I had mentioned earlier, about what the impact it is on endothelial cells, for instance. We had mentioned some of these things that for a diver, what are we worried about? We're worried about hyperoxia first, pulmonary oxygen toxicity, for instance. CNS, perhaps not as much, unless one looks at the idea that COVID may affect brain tissue. But the big one is the pulmonary oxygen toxicity. But we're seeing hyperbaric oxygen being used for COVID-19 infections, and the reports are coming out that they're not seeing problems with that. And as you know, the amounts of oxygen that they deliver during a hyperbaric oxygen treatment is quite impressive, a lot more than you would receive diving. So that's a good check off the box. The endothelial story, not quite sure yet. The idea, does it, how would that affect decompression and that sort of thing? Not seeing anything that jumps out at us. The microthrombi as a result of that, or the interaction of endothelium to the actual components of the blood and microthrombi, that's more in the acute phase. It seems to get better with time. The idea of hypoxia is probably one that is very concerning to me, specifically for breath hold divers. And that's one that we are working very closely with those that do breath hold diving and the physicians that are tightly involved in those kinds of divers, because they live on the edge when they're doing the breath hold diving, particularly competitive. They're living on the edge of that hypoxic border. So the idea that any impact on that needs to be thoroughly looked at. So any recommendations that do come out probably should be very closely followed by those that do the breath hold diving. The other questions about the individuals down in the sea base. It was interesting. The best is if anybody's setting up a program or the absolute details, it's quite lengthy. Stanfill and Angelo, both down there, very great guys. You can give them a call and they would be more than happy to share some of this info. But the gist of it is somewhat like military is doing for some of their trainings. They're keeping the groups of divers, in this case it would be a community, a troop, and they keep them, they monitor them before they come down for all the different things that we look for infection, for any element of infection. This same group then travels down together, they birth together, they're in a barrack setting, which is probably one of those areas that, you know, if you're going to get that, you know, this is where it's going to happen. But that group eats, sleeps, and dives together, isolated on component parts on that boat. The question was, I would say about 50% capacity, maybe a little less, 50% capacity what they normally do because of these accommodations that they've done. The incentive for those that are involved in this is to be upright and truthful, observe the others, make sure that they're not engaged in risky behavior, getting in those super spreader type situations before they take off and fly down to or drive down to the Keys, so that they do not bring that with them. They do not infect the rest, because if it is, then the idea of being in that tight close quarters would affect the whole group and would result in that particular group perhaps not diving at all, and so they'd be taken out of the sea base environment. So it's a cooperation. Whether this can be done, you can see that this is a little different than most of your normal liveaboards or whatnot, where people don't even know each other before they get there, perhaps. But the idea that this is a scouting organization where it's regimented, the way they operate is very, very is regimented to that degree to be able to do that, as opposed to one in which folks are coming from all over the place. So it was a highlight. It was good to see someone be able, especially for kids, to see the kids get something. It's like, good Lord, of all the ones that they really had that have taken a hit as far as some of the isolation goes. It's good to see opportunities like that for the kids to get out there and do stuff.
Thank you so much. So I know we're a little past our time. However, we have one more question if you have time to answer it.
Sure.
So Hyson asked, he has a two-part question. So given mRNA vaccines are new, what is Dan's recommendation for diving between the two doses and after the second dose? And the second question is, if Dan were to study the side effects of the vaccines to diving, what attributes would they be looking for so as we as divers can pay attention to those? Thank you.
Well, that's a good question. We're not specifically looking at that. We are looking at whether divers are vaccinating themselves. It'll probably, just more of a epidemiological viewpoint of, do divers tend to receive vaccines and that sort of thing. So that, and we probably compare to the population as a whole. But the idea would be that the vaccinations would give considerable benefit, as we talked about, the transmissibility of the infection on board the ship of an individual that has received the series and has become immune to the immune at 95% rate, that this would be a benefit. having said that, we still advocate to continue, and basically we'll stick to the CDC guidelines as far as what they're recommending, and they still say continue with measures to prevent disease. Looking at any sort of problems that arise from the vaccine itself, the biggest, of course, is anaphylaxis to the vaccine. Fortunately, that has not been a very large issue. So it appears that the initial, particularly after the second shot, and I can vouch for that, is that you'll get a fairly good reaction where you won't feel well the next day, and certainly diving would not be on that list of activities that you're going to want to do for the next day or two after that. It is a fairly effective response that most will get from that. So looking at that from that point of view, that's probably the way we would look at it. I believe, if I can detect, is some of the concerns of a novel mRNA virus vaccine that actually where replication occurs with the cell. That in itself is something that's being closely followed, and at this point, we're not seeing problems. I hope that this does not result in problems, but again, we're watching that. Certainly, if we saw that, we would report it. That's everyone's responsibility, not just Dan's, but everyone, to go ahead and report that if we were to see some sort of issues or problems where this becomes more relevant, and take measures to address that, because this is an incredible methodology. If you think about it, and this we could talk, is the methodology for developing this kind of vaccine and the implication it has for many infectious problems, and it's opened a doorway. Again, if you have to, I hate silver lining to this horrible pandemic, but the idea that it pushed some of this stuff, almost, if anybody follows like warfare, some of the technologies that occur in an ugly thing like war, and then boom, incredible technologies are birthed. The same thing could be said perhaps about COVID, is some really interesting things have developed both in healthcare systems in general, but also in stuff like vaccine development. It's been, I'm hoping, and it appears in everything I'm reading, that this is quite a remarkable development in man's battle against infectious disease.
Thank you so much, Dr. Chimiak. I think it's safe to say, on behalf of all the participants today, we really appreciate your informative presentation and answering all of our questions.
Well,
thank you.
Well, thank you so much. I really enjoyed this sort of interaction. I'm glad you guys are interested. Those that are divers, that you can disseminate information, that Dan's there, despite the infections and the pandemic. We're still here. We're still battling along. We still got divers out there that are in trouble. They're a little bit more difficult as a result. Some of the evacuations and even getting them back to the States can be challenging, because, as you know, the hospitals right now are pretty much challenged with bed space and that sort of thing. So Dan still works with that and tries to get individuals back, or even having to work with the local hospitals and facilities in those locations to take care of divers. But we'll continue to do so. And if you have any suggestions or comments, or you see anything that we need to do better, or anything you guys need that you think is an important health issue, or something that we can do for divers, we're always all ears. So give us a call at that number. You'll get either my medics or one to the other docs that work with me, and we're always willing to talk diving. So like here, you're all probably saying, when's this guy going to get off the blog? But I could go all night. I mean, it's a fascinating field. I've enjoyed it, in interacting with people like yourselves. It makes it all worthwhile. So thank you.
Again, Dr. Chimiak, thank you. Karen, thank you for arranging this, and thank you to all of the people who joined us tonight. I would like to say thank you to John as well for allowing us to use his Zoom function to make this available to not just our club members, but to members of the scuba diving community here in Canada. And thank you all, and have a great evening.